Good morning, everybody. Welcome to Pediatric Grand Rounds. I'm Jennifer Kett. I'm the division head for bioethics and palliative care, and I'm standing in for Dr. Mazur today. A couple housekeeping items. If you're joining us via WebEx, please submit your questions or comments for the speaker into the chat section. We'll have time at the end for questions after the presentation. After the meeting, you'll get an evaluation from the CME office. Please take a minute to fill this out. Really helps the Grand Rounds team to improve the program over time and maintain accreditation. As a last note, the planners for Grand Rounds do not have any relevant relationships to disclose. And now I'm going to turn it over to Dr. Amy Trowbridge, who will introduce both this event and our wonderful speaker.
Thank you. Hi, everyone. My name is Amy Trowbridge. I'm an associate professor in bioethics and palliative care. Honored to be here today and introduce our annual Mann Family Pediatric Palliative Care Grand Rounds. We are so honored to be able to offer a Grand Rounds every year and bring in a real expert in the field of pediatric palliative care, thanks in large part to Barbara and Eric Mann, who you can see on the slide have been really generous and innovative and thoughtful supporters of the bioethics and palliative care program since 2007. Thanks to their support, we've been able to expand specialized education and training, including this Grand Round. So thank you so much, Barbara and Eric. Today's Mann Family Pediatric Palliative Care Grand Rounds speaker, we are incredibly lucky to welcome Dr. Erica Kay, who is the Director of Quality of Life and Palliative Care Research at St. Jude's Children's Hospital in Tennessee. Dr. Kay is a physician scientist, triple boarded in pediatrics, pediatric hematology oncology, and hospice and palliative medicine. Her research platform centers on improving prognostic communication between clinicians and children with serious illness and their families. Dr. Kay received her Bachelor of Arts from Yale, her medical degree from Harvard, her MPH from Hopkins, and then pediatric residency at Boston Children's Hospital, followed by her 2 subspecialty fellowships at St. Jude. Dr. Kay, her academic work has been continuously funded by the National Cancer Institute, the National Palliative Care Research Center, and many others. She's, I'm going to stop reading my script and just speak from the heart for a minute. She is a true leader in our field for many different reasons. She's received a bajillion awards. I'm not going to name them. But the reason that we've been learning over the last few days that Dr. Kay, I think, really has made such a big difference is her big picture thinking about what the whole field really needs to be able to move forward in research and the care of serious illness, and her incredible, incredible commitment to mentorship and teaching, including mentoring many of us in this room. So we are so honored to have Dr. Kay with us today and to hear from her about hope and realism.
Well, thank you so much. I am really excited to be here today, and a thank you again to the Mann family for their generosity in sponsoring this event. I am grateful to have this chance to talk with you all today about hope and realism and how we navigate this challenging work of partnering with patients and families who continue to hope for cure even in the face of poor prognosis. I have no disclosures, no salient conflicts. Some of the work that I'll describe has received funding from federal and foundational sources. And my objectives today are fourfold. So first, I'd like to describe the importance of how we talk about prognosis, particularly in the setting of advanced childhood cancer. And I'll review some of the evidence that has grown over the last decade around strategies to help us encourage honest, timely, person-centered prognostic communication. And then I'd like to take some time to think about what I consider to be a false dichotomy that pits hope against realism or prognostic understanding, especially in the setting of advanced or incurable illness. And then I'm really grateful to have this chance to share with you work done by a remarkable group of bereaved parents who wanted to reimagine the purpose of hope in the setting of serious illness and at end of life. And I'll share with you their recommendations to help guide us as we walk through this very difficult process of explaining poor prognosis, even as patients and families continue to maintain hope. And so, I think for many of us, we have faced challenges in talking about prognosis, especially as disease advances. And even the most seasoned clinicians among us, I think, would say transparently that they reflect on opportunities to strengthen how we talk about prognosis. And fortunately, improving our communication skills has been identified iteratively as a high priority by a number of national organizations, so specific to oncology, NCI, ASCO, ASFO, the National Academies of Medicine, and many others have identified this as a crucial imperative. And this is in no small part because there are a growing body of data showing that communication skills training can improve how we talk about sensitive topics like prognosis. And this really matters to families. And in some of our earlier work, we demonstrated that parents of children with cancer feel like in general they receive high quality communication about diagnosis and about treatment planning, and yet many fewer parents feel like they receive high quality communication about prognosis, meaning how the treatment is working, likelihood of cure, what the diagnosis might mean for the future. And I think this is intuitive, but really important to note that parents are more likely to feel like they're getting high quality information about prognosis when they concurrently rate their physician's communication style highly, which underscores, I think, the potential for communication skills training to be impactful. And why does this matter? Well, we have evidence that shows that how we talk about prognosis can directly impact the quality of care, particularly in advanced illness. In the absence of clear prognostic disclosure, parents are more likely to overestimate likelihood of cure and make decisions that may exacerbate suffering. And conversely, when parents understand prognosis, children with advanced cancer are more likely to receive palliative care and other interventions that help alleviate suffering. And so our team was really interested in better understanding the landscape of communication skills training in our field. And so we conducted a systematic review of the literature and identified 6 discrete communication interventions specific to pediatric cancer care professionals. And although this is a relatively small number and they were largely single-site studies, we were heartened to see that these studies were demonstrating feasibility and acceptability and potential for impact, particularly on self-reported confidence and competence with prognostic communication. And so as we began thinking about, how might we design further interventions to help support prognostic communication, it became clear that we needed to have better understanding of what the state of communication science was in our field. How were we studying and trying to understand sort of what communication looked like and how to improve it. And around that time, there was growing awareness that prospective investigation of actual recorded dialogue was the gold standard for advancing communication science. And so we conducted another review of the literature, this time looking at, what did communication research look like in pediatric oncology? And we identified about 24 studies that were almost entirely cross-sectional and retrospective, so limited by single time point and recall bias. And at that time, there were no studies in which actual audio recordings of high-stakes sensitive conversations were captured across an advancing illness course at those disease reevaluation time points when it was most likely that prognosis could or should be discussed. And so that became the foundation for developing and implementing the UChat trial, which stood for Understanding Communication in Healthcare to Achieve Trust. And UChat is a prospective longitudinal mixed methods study in which we audio record serial disease reevaluation conversations for children with high risk or poor prognosis cancer across the illness course for 24 months from whenever they last relapsed, with the clock resetting at each relapse or until they died. And in addition to recording all of those real-time conversations, we also collected ancillary data with surveys and interviews, particularly following what we called bad news conversations, when there was discussion about disease relapse or progression. And I will pause to say transparently that when we first proposed this study, there was a lot of pushback because something like this hadn't been done, certainly at our institution, really hadn't been done in our field. And there was a lot of trepidation about the burden, the potential for harm, that oncologists wouldn't be willing to do it, that patients and families wouldn't want it. And we struggled to very slowly socialize this idea and get enough buy-in to be able to do the study. And we started with a pilot, and we were pretty heartened to demonstrate very high feasibility and acceptability for this type of communication science. We were able to capture nearly every longitudinal data point, and the study was highly acceptable, with oncologists absolutely buying into the work, not only allowing the recordings, but opting into doing all of the surveys and interviews, even though they were optional. And most parents felt the same way. And although this study was not designed to benefit any of the participants directly, and we were very clear about that, we were interested in generating new knowledge to help people in the future, and yet, when we asked parents as part of our data collection materials out of curiosity, how did you feel about this engagement? Most described study participation as useful to them. And in some of our conversations yesterday, we were reflecting on how parents who opted in to doing, again, these optional interviews, which were designed to be very brief, like could be done in 5 minutes, some of them talked for hours. I mean, the record was, I think, 4.5 hours. And so there was, I think, absolutely a feeling of benefit on part of the participants, which is important for us to carry back to our institutional and scientific review boards to help advocate for this type of work. And so, as you might imagine, UChat collected an enormous body of data. We enrolled many patient-family dyads, patient-parent dyads, and that yielded hundreds of serial medical conversations, totaling many thousands of minutes of recorded dialogue. And this enabled us to conduct qualitative and mixed methods analyses across a wide variety of topics, including how we talk about prognosis across evolving illness, what language we use to build trust and therapeutic alliance, how we engage in conversations around various palliative care principles and advanced care planning, strategies for how we segue into goals of care conversations, which can be a particular challenge in these visits, language to support person-centered and dignity-centered care, and even the absence of language. So how do we leverage silence to create very meaningful moments during these conversations, and other topics as well. And I will not obviously go through all of these data in detail, but I will point out some of the findings that I think are most salient for our conversation around how we support hope in the setting of serious illness. And so one of the things we were really interested in understanding up front was how often we talk about prognosis and what that content looks like, and what impact it might have. And we were incredibly generous in how we conceptualize the idea of prognostic communication. So a priori, when we developed our code book, any statements about how the illness might impact the child's future in any way was coded as prognostic communication. And despite that, you can see that very little of our recorded dialogue involved prognostic communication. And when we triangulated those data with the survey and interview data that immediately followed the recorded conversations, we were able to look at a number of variables, including concordance in prognostic understanding between the parent and the oncologist around likelihood of cure, and found, in a way that I think is likely intuitive to many of us, that there was often discordance in prognostic understanding following recorded conversations where there were not statements made about the child's likelihood of not being cured. And similarly, there was concordance achieved in most cases after the oncologist made direct statements about incurability. And I think although this is intuitive, it bears underscoring because we don't always make those direct statements for various reasons. And we were really interested in looking at, what are the different ways that we might broach prognostic disclosure, not just at single time points, but across the advancing illness course, because we all know that these conversations are not and should not be single conversations. And we found three main discrete patterns for how we talk about prognosis. And the first is an avoidant pattern, where either there were no statements about how the illness might impact the child's life across serial visits, or there were prognostic communication statements, but often focusing on the positive or downplaying findings. And then there was a pattern that we called a deferred pattern. And oftentimes in this pattern, clinicians would focus a lot on details of disease progression, exactly how much a nodule had grown, where the metastases were, and then granular information about treatment options, but without necessarily connecting that to the big picture of how this will impact the child's future life until either the penultimate or ultimate recording prior to a child's death. And then the final pattern that we saw, we coined a seed planting pattern. And I thought this pattern was incredibly interesting in that even at time points of relative disease stability, the oncologist might make "I worry" statements about the future in a way that to us felt like they were planting seeds to grow prognostic awareness slowly over time, allowing families to acclimate to and process impossibly hard news, and then to be able to reflect back as disease progressed on those prior worries. And when we started socializing some of that data with colleagues, we received a consistent message back, which is sure, but some oncologists are just good at doing that type of seed planting dialogue, and others aren't. And you'll never be able to reach the people who are never going to do seed planting. And so I thought that was a valid point, and we went back and re-examined the data and discovered through that lens that in fact, every oncologist in our study across different disease types used seed planting in some of their patients and families. And no oncologist used it consistently with everybody. And to us, that suggested that there is openness to this approach, that people may see value in it, and that perhaps we could be encouraged to use it more consistently. We also looked in more depth at a case series of oncologists with patients and families who had used very conspicuous seed planting across the illness course. And so we did an in-depth analysis describing the different language strategies and approaches in these cases, and again demonstrated that you could see improving concordance and prognostic understanding as seeds were planted over time. And I will absolutely asterisk that those data are descriptive, exploratory, and associative. They're not causal, and I still think that they are compelling and worthy of further examination. Another finding that we didn't anticipate that became very clear early on in our analyses was that there was dramatic variance between what oncologists said in the room, forward-facing to parents and patients, and what they said immediately after they stepped out of the room to colleagues or researchers. And we called this mismatch or variance. And more specifically, in nearly every oncologist interview at time points of frank disease progression, oncologists predicted curability to be 0 or very unlikely. And yet, most of the time, as they were describing odds of cure as negligible to our research team, in the conversation that had immediately preceded that description, they did not communicate those low odds to the patients or families. And so what did we communicate? Well, we found a couple of patterns that we described overall as a softening of prognostic communication. And one of the main patterns most frequently seen was what we called space holding for hope of cure, which I think is a really important and meaningful and high quality communication skill. And also, some of the pillars upholding the space holding for hope of cure pattern involved things like minimizing language, saying that treatment might be effective even if we didn't actually feel that to be true, or saying, well, we just can't know for certain. And I think what's most striking about these pillars in the space holding pattern here is that in each of these cases, you can see we use a lot of language in the room, but when we come out of the room, we say quite definitively, 0 chance of cure. We also saw patterns that I think fall under the auspices of softening around giving vague warnings that don't necessarily connect the dots for patients and families, or giving a lot of data without interpretation. And again, you can see that often in these contexts, when we triangulate that with the data of what they say to the research team right when they step out of the room, there is a mismatch of saying, very unlikely to be cured or no chance of cure. We were surprised in our data to end up with pockets of analyses that we had not anticipated. And one of those involved what we ended up calling equivocal encounters, because when we initially conceptualized the study, we assumed that we would be able to dichotomize medical encounters into either good news or bad news, either disease was stable or had regressed or improved, or disease had progressed or relapsed. And what we found was that there were a sizable minority of recorded encounters where the oncologist was unwilling to commit to that the disease had progressed or was stable, and felt like, well, that nodule is larger, but maybe that one is a little bit smaller. And so we had to amend the protocol to create a third category for equivocal conversations. And we ended up with, I think, a decent chunk of our conversations, about 15%, were equivocal, and that entailed hundreds of minutes of dialogue. And so we did an analysis specifically of those conversations, and it found that we talk about prognosis even less in those equivocal encounters, and that it was entirely absent in about nearly half of conversations. And we found direct curability statements in only 2 out of 40 conversations. And when we did make statements related to prognosis, what the disease might mean for the future, usually it fell into 4 main patterns: upfront reassurance or softening of the message or minimizing language, describing disease progression without interpretation, or expressing uncertainty without connecting it to the bigger picture. So you can see very similar to the prior data. And I really want to underscore that I don't think there is anything inherently wrong with any of these 4 patterns of reassurance or softening or describing disease progression or expressing uncertainty. I actually think those are pillars of high quality communication, and they can be strengthened by what we consider to be 2 simple approaches: a "this means" statement, or one of the 3 W's: I wish, I worry, I wonder. So for example, instead of saying the stuff in her lungs is worse and then moving on to talking about specifics of different treatment options, we might say the stuff in her lungs is worse. This means that the cancer may be back and the medicines we're using may not be working like we hoped they would. And if that's the case, I worry we won't be able to cure her. Or instead of saying, in some places we worry it might be getting worse, but nothing we can say for sure, and then going on to talk about something else, we might say, in some places I worry it might be getting worse. Nothing I can say for sure. I wish we weren't in this situation. I know there's a chance the cancer is progressing and we won't be able to cure it if that happens. I wonder if you've thought about what would be most important to you in that situation. We also were surprised by a pocket of patients who enrolled on the study because of eligibility with respect to high-risk disease, and also concurrently enrolled in phase 1 experimental trials, and then had their disease remain stable over the course of the study window. And that was exciting to us because it gave us an unexpected opportunity to analyze recorded conversations for patients where oncologists were worried that the disease would at some point return, and the child was still likely to have a poor prognosis, but there was a very prolonged period of disease stability. And what we found is that we very rarely talk about prognosis during these encounters of disease stability. And in the less than 4% of time where we were talking about what the illness might mean for the future, nearly every one of those coded statements were "I don't know" statements. There were very, very few statements about likelihood of cure. And again, we found 3 patterns: a don't know pattern that fell into that sort of longitudinal thematic pattern of avoidance or deferral, but we also found some examples of worry or relief caveat statements, preparing families for future possible progression, and balancing positivity with caution, which we thought were really beautiful examples of a seed planting approach. And so, why study in this amount of detail how we talk about prognosis? Why try to help us be clearer or more person-centered in our approach in prognostic disclosure? I think there are many human-centered reasons for doing this, and I think that the data show us clearly that it actually matters profoundly. And I'm sharing with you one of our studies that was conducted as a mixed method study across 11 cancer centers around the United States, in which we followed longitudinally families of children with relapsed refractory neuroblastoma and surveyed them about a variety of experiences in their child's illness course. And one of our main hypotheses, a priori, was that a parent's perception of very intensive treatments where the side effects vastly outweighed the perceived benefit, or seeing that treatments were failing the child, or perceiving that the child was suffering, that these variables would be in some way associated with an evolution of reporting a goal of cure to then transitioning to a goal of comfort. And what we found was that, in fact, none of those variables were associated with evolving goals of cure from cure to comfort. In fact, the only variable that was associated with transitioning to a goal of comfort was if the parent recalled communication about prognosis from their child's oncologist. And again, I think this data is not shocking. It's likely intuitive to many of us, and yet I think still bears underscoring, particularly when we view how little we talk about prognosis relative to other things that we're talking about in the room. And I think these data, moreover, underscore the importance of evidence-based interventions to help encourage timely and person-centered prognostic communication, not just in advanced childhood cancer, which is my area of expertise, but I think in the setting of serious childhood illness. And so these data were foundational for the development of the Right Time Study, which stands for Revealing Information Genuinely and Honestly Across Time. And this study is predicated on the belief that to improve prognostic communication, we must first characterize what our key community members at the heart of the question that we're studying feel is the right way to talk about prognosis. So we know what's happening right now, but we don't know what our key community members think is the gold standard for talking about prognosis. And then we need to partner with those community members to help develop a conceptual model or framework to then support the design of an intervention for supporting individualized prognostic disclosure. And then we need to pilot test that intervention, again in alignment with the values of the community members affected by the question. And so the Right Time Study is a 5-year study funded by NCI. And in the first phase, we conducted a large number of in-depth interviews with nearly 100 patients, parents, and oncologists. And we talked to patients and parents across a variety of time points in the advancing cancer course. And then we gathered a smaller group of key community members, again comprising patients with advanced cancer at different time points in their illness, parents of children undergoing active treatment, parents of children with cancer who had died, and oncologists. And we partnered with them to co-design a conceptual model and then an intervention to help support individualized prognostic communication. And we are just now entering into the 3rd phase to test that intervention. And I'll share with you, though, some of what we've learned preliminarily from phase 1 of the study, which is that when we talk to our patients and parents, the majority of them still describe negative experiences with prognostic disclosure. And parents more often highlighted these very distressing experiences. Patients did not verbalize them as much. But even the patients who did talk about it had very profoundly distressing experiences. And the 3 main themes that patients and parents noted sort of underpinning their perception of poor quality communication really fell into three buckets. They felt like they were not getting enough information, that the doctor was withholding, that the doctor knew more than they were saying, which I think dovetails with what we saw in the earlier data around mismatch or variance in what we share in the room and outside of the room. Or they felt overwhelmed, often because they were hearing contradictory information from different people. And I think one of the most prevalent themes was this feeling that the communication about prognosis was not individualized to them. It wasn't person-centered. They didn't feel connected during that conversation. And that was so important to patients and families. And so when we started probing more into, what is the right way to talk about prognosis, we got so much data. And we divided into three main categories or buckets to explore, sort of when, how, and what to talk about with prognosis. And I won't go through that in detail, but I really want to underscore what I think is the takeaway message, which is that patients, parents, and oncologists advocate for diverse and at times quite conflicting approaches for best practices for prognostic disclosure. And I think, again, this shouldn't surprise any of us because we are all unique individuals who have different preferences. And it's really important for us to remember this because, although every one of our cohorts, patients, parents, and oncologists across different time points, emphasized the need, the value of individualized prognostic disclosure, oncologists endorsed that they rarely elicited those preferences for prognostic communication before disclosing. And more often, oncologists described inferring or assuming what they thought the patient wanted or needed or was ready to know. And I think that there might be a lot of truth inherent to that approach. You might be right in that assumption, but because of the diversity of preferences, I think we have to acknowledge that our assumptions may not be right, and we might not know how patients and families want prognostic information to be disclosed unless we ask them. And so we wanted to explore in more depth this idea of if or how we should elicit prognostic communication preferences, and we found that almost all patients and parents wanted the oncologist to ask them about their prognostic communication preferences before prognostic disclosure. And fewer oncologists advocated for this approach, I think in part because no one had a specific practice for doing this. It's often not a part of our standard difficult communication skills training, although I think some places do try to practice this. I think many people are not comfortable or familiar with eliciting prognostic communication preferences. And again, patients and parents shared with us several reasons for why they felt like this elicitation was important, because they felt like if you individualized the information about prognosis, it helped them better think through goal setting with you, and that it actually protected their mental and emotional well-being, which I think is counter to what sometimes we as clinicians feel like it's going to be awkward, it's going to make them distressed if we talk about this in advance, and that's not what patients and families shared with us. And then patients and parents recommended targeted strategies for how we might think about eliciting prognostic communication preferences, largely focused on asking very open-ended questions to start, and then normalizing the process by sharing some patients might want to receive information in this way, others in this way. Both are okay. What feels right to you? And I want to highlight again how what oncologists think is the right way to talk about prognosis is sometimes, but not always, shared by patients and parents. Many oncologists talked with us about how they are always open to talk about prognosis, but they don't want to push it on people. They want to wait for people to be ready, and so they're sometimes waiting to be directly asked, and in that way end up, for a period of time, falling into an avoidant or a deferral pattern, as we saw earlier. Others shared that, up front, I don't give numbers or population data because I think that's harmful, or they felt like softening the message was critical for allowing people to maintain hope, or again, they made assumptions about what a family was ready or wanted to hear and were not comfortable with language to explore what they wanted to hear about prognosis in advance. And I want to directly compare this to what patients and parents shared with us, which is that nearly everybody wanted direct, clear, and frequent prognostic communication. And they want us to do so compassionately, but they want to hear anytime the doctor knows something new, they want to know it too, which means that they want to hear communication not once, but multiple times if there is new information that affects how the illness might impact their child's future life, and that this desire persists even or especially in the setting of poor prognosis. And at the same time, they want us to create space for hope. And I think this is where the tension lies, where I can say for myself as an oncologist, I start to feel a little uncomfortable. How can I be direct and frank and make sure they know everything that I know and create space for hope? And I'm not going to go through the conceptual model in detail, although I think it is lovely and a credit to the patients and parents that invested many months into developing it. But I want to point out that when we talked about what prognostic disclosure should look like in its multitudes, the idea of creating space for hope came up so often that we actually had to pause and redo the model to physically create space for hope in order to honor the themes that were emerging in these conversations. And so I want to transition now and talk a little bit about hope and what that means. And for me, I've spent a lot of time over my career thinking about hope, and I have settled on two words that I think encapsulate hope, which is that it is necessary and that it is tenacious. And I'll share with you that in my life prior to medicine, I was a poetry major, and that was a very big part of my personhood and how I think about the world. And so when I seek wisdom, I turn to my favorite poets. And Langston Hughes is one of my favorites, and he writes an extraordinary poem called Dreams, in which he says, "Hold fast to dreams, for if dreams die, life is a broken winged bird that cannot fly." And I think about this poem often because in the context of serious illness, I think nothing is more true. But without hope, you're a broken winged bird. You can't fly. You can't get out of bed in the morning. That hope is absolutely essential. And I think we see this necessity of hope nicely described in the literature, with parents describing hope as life-sustaining, recognizing that it's a mechanism for coping, that it can be a source of resilience, and seeing how it impacts decision-making across advancing illness and at end of life. And I think that it is necessary but not sufficient to describe hope as essential. I think it's imperative that we recognize hope as tenacious, as extremely sticky. And Dickinson is another one of my favorite poets, and she writes a pretty famous poem called "Hope is the Thing with Feathers," which goes, "Hope is the thing with feathers that perches in the soul and sings the tune without the words and never stops at all." And I think we see this reflected profoundly in our work at the bedside, that no matter what obstacles a patient or family is facing, there's always hope. Hope is sticky. It never goes away. And again, we see this reflected in the literature, where transparent disclosure of prognosis, even incurable illness, often does not diminish hope, that parents will remain hopeful irrespective of gravity of the prognosis, that it persists in the face of critical illness in the ICU, on ventilators, on 3 pressors, even as the child is actively dying, and that hopes are fluid and evolve. And I think this can be very tricky for us to navigate at the bedside. And we often feel like we are in a balancing act, where on one hand, we don't want to give people false hope because that feels not fair, not just. And we don't want to take away all of their hope because that feels not compassionate. And so how do we navigate this delicate balance? And I think part of the problem is that we have an erroneous perception of hope as a zero-sum game necessitating trade-offs. And I think in some ways we almost view prognostic disclosure or prognostic understanding like a negative integer when superimposed or added to hope, that it obliterates all of the hope that's there. And I think that that paradigm, or that idea of a necessary trade-off, actually encourages us to avoid or defer prognostic information, because from a place of well-intentions, we're trying to preserve hope. And we see this tension between sustaining hope and expressing prognostic understanding for patients and families at the bedside. And historically, this tension has been characterized by the analogy of a swinging pendulum, sort of reflecting how a parent might in one moment say, I hope my child is going to go to Disney World, and in the next moment recognize that their child is dying and unlikely to live, another week or so. And I think in many ways this pendulum metaphor served us well. I think it advanced dialogue and understanding. And I think in some ways it distracted us and perhaps even waylaid us, in part because it became easy to conflate hope with denial. And on the other hand, to then label patients or families who verbalized prognostic awareness instead of their hopes as being the savvy families, the ones who get it. And this is what I call the pendulum model fallacy, this idea of an undue opposition created between hope and prognostic understanding or awareness, which I think is a false dichotomy, this idea that either you're hopeful or you have realism or prognostic understanding. And this is codified by the pendulum, because the ball can literally not exist in both spaces simultaneously. It becomes a dichotomy of either or. And I think this has very real unintended consequences that we need to reflect on. When we misinterpret hope as refusal to accept reality, I have personally seen this cause needless friction between families and clinicians at the bedside. I've seen it cause tremendous moral distress, particularly for nurses who spend many hours at the bedside caring for children as they approach end of life, when they hear a parent expressing hopes that they view as not realistic. It can cause extreme moral injury if the assumption is that the family doesn't get it or the oncologist never told them. And I've seen it cause us to repeatedly flog a family with a grim prognosis because we just want to make sure that they don't have false hope. And this can cause a lot of unintended harm. And so then how do we nurture hope in the most barren of circumstances when we understand the reality? And I think that we do this powerfully through compassionate communication. And so I want to transition and share with you lessons that I've learned from a remarkable group of bereaved parents. And this is a picture of the original founders of the Quality of Life Steering Council when it was just a few members. And over the last almost decade, it has grown enormously, diversified quite substantially. And this group comprises largely bereaved parents and also a group of wonderful multidisciplinary professionals with expertise in advanced illness and grief and bereavement. And the overarching mission of the Quality of Life Steering Council is to help advocate within our healthcare system for greater clinician awareness of what patients and families need, not just across advancing illness, but at end of life and beyond. And so a group of about a dozen parents from this steering council chose to form a forum that we called the Hope Forum. Here are parent experiences, and their goal was to think about reconceptualizing the role and function of hope in advanced pediatric cancer. And the questions that they wanted to consider were, what did hope mean to you during your child's illness, particularly towards the end of life? And did you ever feel hopeful and realistic at the same time? And if so, how? What did that look like or feel like for you? And so our Hope Forum met both in person, face-to-face, and online over a number of engaging conversations. The parents shared stories with one another as well as shared prose with the collaborative group. And researchers then compiled, organized, and synthesized parent responses. And then parents and clinicians came together to discuss those materials and create a consensus report. I apologize. And so when we partnered with the parents who were co-authors on this paper, they really were the drivers of this new knowledge. They wanted to emphasize that there are three overarching buckets of hope, and these are not mutually exclusive. The first is hope for cure, which again is necessary and tenacious. And there's hope for life beyond illness or return to normalcy, and that can look like many different things. A life beyond illness does not necessarily mean cure. It might mean death and a relief from suffering. And they hoped for comfort. And they also thought about the function of hope through 6 unique mechanisms. Hope as an action, as a verb, as something that you do. Hope as a survival mechanism. Hope as validation of one's role as a good parent. Hope as ever evolving. Hope as leaving space for a miracle with a lot of anchoring and faith, an existence of hope in the moment of death and beyond. And as we tried to synthesize the parents' thoughts and create a working definition, we ended up feeling very strongly like we needed to create this multifaceted definition in their words. And I'll share with you some of what they taught us, that hope is the antithesis of despair, not the opposite of reality. That to be hopeful is a function of the heart and a decision of the will. Again, there's that to do, the action verb. Whereas to be realistic is merely a function of understanding the most likely outcome. That hope is a choice, a decision to not give up. It's not about the outcome. That hope means I can be here even though here is an unthinkable place. And that hope is how I cope. Without hope in something, there's no point to anything. And I think you can hear the echoes of the poetry in their words. When we talked about the possibility of how hope and realism could coexist, we were very humbled and a bit awed by how much unanimity there was in the belief that when you face the death of a child, you invariably experience both profound hope that your child will survive and coinciding understanding of what the medical team is saying to you. And one parent said beautifully to us, partner with us and witness the transformative love of hoping for the impossible while accepting the painful reality that our rare and beautiful child is gracefully exiting this world. Another parent emphasized that hope and realism are not mutually exclusive. They're not at odds with each other. They don't need to be in balance. That 2 parents or a parent and a clinician can share the same view of reality and not necessarily the same hope. Another parent described a big umbrella over their journey where they had a constant hope that their child would survive and also realistic hopes under that big umbrella. Another parent said, we're living every day as if it were my child's last and also as if he might live forever, and that's hope. And I loved the analogy that one parent shared, that there was then very rich discussion around the idea of why would you buy a lottery ticket? The odds are terrible. They're stacked against you. And yet having a lottery ticket in hand, even for just one day, gives you the chance to dream and wonder. And that's what it felt like to her. That hope gave her the opportunity to dream and wonder about the possibility of her child beating the odds, even in the face of understanding a grim prognosis. And so then we reached a very interesting point in our discussions where we wanted to create a novel figure. And we partnered with a very talented and very patient team of graphic design artists, and we presented verbatim language to them to help guide figure development. And they brought many figures to our forum, and they were all summarily rejected. and I give this team so much credit. They stuck with us. They were very moved by the parents' storytelling, and they wanted to honor their journey and the new knowledge that they had generated. And the youngest artist on the team came to me privately after one session that had not gone well and said, this might sound crazy, but I think what you're trying to do is create art. I think you're trying to create a painting. And I said, tell me more. And they created a watercolor and brought it to the parents, and the parents said, yes, this is what we're trying to say. And I am going to share the painting with you and read in their words how this makes them feel. In this model, which they called Hope Springs Eternal, a figure exists within a windswept circle of flowers, simultaneously watering the flowers while also cradling a flower as its petals drift away. The figure is intentionally amorphous, androgynous, ageless, and not affiliated with a race or ethnicity, allowing space for diversity of representation. The swirling circle is evocative of the life cycle, the flowers illustrative of the beauty and fragility inherent to life. The watering can symbolizes the good parent role and the parent's intrinsic hope to continue supporting and nurturing the child. At the same time as the parent pours life into the child, the parent also acknowledges the falling petals and gently allows the child's spirit to let go. Importantly, even as the petals fall from the hand, the flower does not lose its wholeness, nor appear any less. The figure who continues to hold the flower symbolizes the ever-present awareness of a parent who lives with the reality of a child's death while simultaneously continuing to live. The flower also symbolizes the legacy of the child's life, which families carry with them forever, even as they grow and nurture new generations of life. The petals fall both downward and upward, reflecting the power of a child's life to continue influencing those still physically living while also making an eternal impact. The flowers being watered swoop upward to the flower that is held, epitomizing the tangible connection the living continue to have with the child who died. Importantly, the caregiver also is seen watering other flowers, alluding to the daily responsibilities that exist to nurture family, friends, and work. Even in the face of deep grief, the realities of duty, love, and life go on. And so when they came together with their pillars and their action points and now their painting, they generated what we called the Hope Consensus Statement, which was three-pronged. They wanted to unanimously underscore the ever-presence of hope as indispensable, not despite or in opposition to realism, but because of their prognostic understanding. They wanted us to understand that hope and realism can coexist simultaneously, and they encourage us to partner with them using this framework of hope and realism. And so this distilled into 10 specific recommendations for how we might communicate about hope in the face of very poor prognosis. And the first point that they made was to foster this partnership by sharing in hope, which I think many of us do beautifully, to say, yes, I hope for that cure with you. Or if they're a faith-based family, to mirror their language, I pray for a miracle with you. And to be very purposeful about not judging hopes as realistic or false. And through this experience, I have grown to believe very strongly that there is no such thing as false hope. Because hope is a wish, a dream for a future. And there's nothing false or untrue about a dream or a wish. And you can have that type of dream and also hear compassionate communication about what we know from a medical standpoint is happening with the illness. They wanted us to validate a parent's hope and to own that that was not false hope, that we can say, I hope with you for a miracle, and I know that it is so important to you that I always be honest and transparent and tell you what I know. This is what's happening from a medical standpoint. They wanted us to acknowledge and normalize the tension that exists when a parent feels compelled to verbalize hopes while also facing a grim prognosis, and that it's okay to say, I can't imagine how hard this is for you, to be hoping and praying for that miracle, which we share with you, while also hearing and understanding what we are telling you. They want us to view hope as life-affirming as opposed to death-denying. And I think this becomes particularly important in our conversations outside of the room, when we're chatting with other members of the multidisciplinary team that we be very careful and attuned to how we use language that suggests that families who hope are in denial or don't get it. They want us to reframe hope as a salve, as a means to ease rather than to deny the pain, as another tool in a toolkit for coping, and that we can again name that for families, that it is okay, it is normal to hope, that is how we get out of bed in the morning. They want us to remember the good parent principle, that many will consider maintaining hope and verbalizing that out loud to absolutely be essential to their role as a parent. And even if they are fully understanding of the details of approaching end of life, oftentimes verbalizing the hope is much more important to them in their role and who they are than verbalizing prognostic understanding. They want us to recognize that hopes evolve and to be very open to exploring new hopes. And so, as many of us are trained to do, say, what are you hoping for? And when someone says, I hope for cure, we say, I share that hope with you. And what else are you hoping for? And what else? And to not stop asking that question even as illness progresses or as end of life becomes imminent, because there are always things that families are hoping for as situations evolve that we can partner with them on. Remember that for some patients and families, maintaining hope is actually how they conceptualize being able to facilitate a good death. And that's not necessarily how we at the bedside might feel, but it's really important that we realize that their hope out loud that their child may go to Disney World is part of how they are facilitating their child's graceful exit out of the world. And then finally, recognizing that reliance on hope is not necessarily or inherently harmful. To my knowledge, we don't have any data to suggest that parental hope for cure at the end of life is associated with poor outcomes such as complicated grief. And actually, one of our trainees is now doing a beautiful study on hope during hospice that I think is going to have compelling data to suggest that actually hope in its variety of formats, even at end of life on hospice and beyond, may be protective in families' grief journeys. So ultimately, I think that these data help us remember that no matter how difficult or winding a road, there's always something to hope for. And it's our privilege, and I think our responsibility, to support patients and parents on this journey. And there are so many people to thank who have supported this work. As tradition over the last decade, I always name the children of the parents who helped us in whatever data I am presenting. And so this presentation is in honor of Nick, Sam, Sydney, Thomas, Katie, Josh, Trevor, and Sean, and all of the patients and families who partnered with us. And I welcome any questions.
Thanks, everybody. We have time, I think, for one quick question.
Sorry, I talked slower.
Thank you so much for this presentation. I think it was such a, the nuance and gray of these clinical scenarios, and you bring some clarity and some meaning and purpose, I think, was really special, so thank you. I'm curious with patients who don't speak, or families who don't speak English, and the nuance of grief and hope that is existence in body language and other forms apart from verbal communication. Is there discussion with your research team about expanding to not just recording, but video recording or other ways for families to express their thoughts?
There are so many facets to that conversation. So yes, we've talked a lot about video recording. We were very focused on feasibility of the study, and there were many reasons why it felt like video would not be feasible, but that doesn't mean we couldn't do it in the future. We have expanded subsequent studies to include families who speak any language, which I think is important. And I have several trainees who are specifically studying how we provide support across advancing cancer for families who speak languages other than English. And I think you're right that not everything is a one-to-one translation. And, for example, there's a trainee who's looking into right now the 3 W's: I wish, I worry, I wonder, which do not intrinsically translate one-to-one into Spanish. And so how might we think about the same feeling and tenor of those words in a way that better translates? And so I think there's a lot of room to explore how we extrapolate these data outside of English.
I'm just going to offer to folks here that and online that today at noon in the Anna Kleiss boardroom, Erica has graciously offered to join anybody that's interested in lunch from noon to 2 to talk about sort of the clinical implications and continue this conversation further. So if anybody is available, you don't have to stay for the whole time. You can come grab a taco and talk about hope with us. And a lot of that is thanks in large part to Cherie Smith, our amazing admin for the Mann Family Grand Rounds, whose birthday it is today.
Oh, happy birthday!